My name is Dr. Simon Kigondu. I am the COG Central Branch Chairman. And with me today I have Dr. Mary Njoroge, who will be our MC. She's the Vice Chair of COG Central. We have a team of people from the registration there and from the COG's national office. We have our accountant there who is helping us with the registration and all. We have our photography team, Skajes and his team. This COG Central is unique for two reasons. One, we have come to Meru for the first time and we want to thank the Meru team for welcoming us. Secondly, we want to sometime later in the afternoon launch an Adopt a Pre-Intern project, which we have a few pre-interns and a few gynecologists, which is a mentorship program where we match pre-interns who are having a period of staying out after finishing medical school so that their knowledge does not decay, and they also get mentorship from the doctors. So it's called an Adopt a Pre-Intern program, which we will do between 5 and 6. This year also is the first year that we are doing a symposium without our treasurer, Dr. Winnie Mwadia, who passed away on May 7th of this year. And in her honor, just before 6 o'clock, before the dinner, we will have a small program in memory of Dr. Winnie Mwadia. In between there, we will have an award ceremony for 4 of our distinguished COG Central members, again at around between 5 and 6, and we give awards to those ones. So every year there's an award ceremony for that. Before all that, then, we will be having presentations. We want to recognize the people who have partnered with us to make this symposium a reality. Outside there, we have about 10 sponsors, and I want you people to really interact with them and see what they are presenting. And some of them will also be giving short presentations here, just for us to sensitize on what they are marketing, and so that we can continue with these partnerships, which is an important thing for us. With that, I want to welcome our first presentation, which is will set the stage for our theme, and it is none other than our FIGO president, Professor Beatrice Kihara. She will be online, but she has already sent a presentation which will run for about 28 minutes as we are settling down. Professor Kihara has been the president of all gynecologists in the world for the last now 4 years, and we hope to usher her out during the FIGO Congress in October this year. So let her set the stage, then after that we will continue with our scientific presentations.
Greetings, colleagues and friends. Today we will be talking about every woman, every newborn, everywhere. What previously was known as Every Newborn Action Plan and Ending Preventable Maternal Mortality. Healthy beginnings for healthy futures. What is your role as COG Central Branch? The outline of my presentation will have a background, give a little bit on awareness history, the global performance indicators, and what is really needed in Kenya for acceleration of reduction of maternal and neonatal mortality towards sustainable development goal 3, and the significant role of data for action. I want to acknowledge the invitation by COG Central Branch to share my insights, and particularly in today's dispensation, when we have global stressors of wars and conflict, geopolitical turmoil, reduction in socioeconomic status, but above all, to constantly keep us on that treadmill that tells us every woman and every newborn should be valued as the human capital for today and tomorrow, and for generations to come. Because how you treat a woman today, her outcome of her pregnancy today, has a bearing on the quality of the citizenry for tomorrow. I have no conflict of interest and no financial support provided for this presentation. Let's start at the beginning. Sustainable Development Goals. We're in 2025. We've got less than 5 years to go. Will we really achieve Sustainable Development Goal 3.1? Less than 70 per 100,000 in maternal mortality? And certainly less than 140 on the upper limit? Are we going to achieve stillbirth rates less than 12 per 1,000? Neonatal mortality rates less than 12 per 1,000? And will we really attain universality of health coverage with no financial hardship, with patients being able to access essential and emergency healthcare packages? We need to have a real rethink. And as if that's not enough, the quality of care and access to essential medical products and medical technologies for all. It speaks, therefore, to health equity, address the humanitarian and fragile situations, climate change, but above all, what are we doing as far as total fertility rate is concerned, contraceptive prevalence rate, unmet need for family planning, both upstream and downstream following pregnancy, or even post-abortion outcomes? What is our primary healthcare conversation for health promotion and preventive strategies and moving our Kenyan citizenry towards wellness and moving them away from the disease paradigm, particularly related to pregnancy and related complications? This was recognized way back in 2014 at a World Health Assembly, where they began to articulate preventing neonatal mortality and stillbirths, but quickly followed it in 2015 with recognizing you cannot talk about the baby without addressing the mother. And by 2020 had come up with 4 prongs, at least 4 antenatal visits, skilled birth attendants at every birth, postnatal care within 48 hours of both the mother and the baby, and care for the small and sick newborn when identified. But in 2021, they began to see emergencies need to be addressed within 2 hours. And we all know the 3 delays, mothers recognizing they have a problem, transport as a major hiccup, which then speaks to even broader social determinants. Who is making the decisions for her care? Who is providing the transport finances? Who is providing the woman with the education so that she has these decisions at the forefront? More and more emphasis on reduction of stillbirths was also brought into vogue. And when we follow through from 2021, we're now in 2025, what are we seeing? For some reason, we're not accelerating as we had done with the Millennium Development Goals. We're plateauing and in some cases even going backward. And this is what has informed EWENE, acceleration plans to attain Sustainable Development Goals. Put differently, figures don't lie. 2.3 million newborns are dying worldwide, 4.9 million children under 5, 1.9 million are being born as stillbirths, 287,000 maternal deaths are happening. Mark you, this is data of 2020, 2021. Yet we know we got COVID, a bigger hiccup that may have even aggravated our situation, and possibly a lot of nations have not recovered. As if that's not enough, the US directive has a bearing on maternal newborn health, on communicable diseases and non-communicable diseases in this side of our world. Issues of lack of manufacturing within our setup, issues of lack of collaborative partnerships, including with private sector. We are trying today, but what is the ramifications for women and their babies? We look at South Asia and Sub-Saharan Africa, and you look at the antenatal 4-time visits. Again, you can see the inequities that do exist, and the disparities ranging from 20% to 40%, where you're lucky. In a few nations, as you move towards China and the Russian area, and even to Southern America, then we're getting a little bit better. At least we're reaching the 80% mark. What is it we're not doing right? Emphasizing on Sub-Saharan Africa, looking even within nations. So within Kenya, within Tanzania, within Rwanda, within Uganda, within Nigeria, you begin to see subnational disparities. So it is not enough to just look at national data. The global trends still offer a picture. Are we attaining the 90% antenatal care with 4 visits? No. Are we attaining the 90% of skilled birth attendants? No. Are we attaining the 80% of PNC care for mother and baby? No. Question. Think about your county. Where are you? Stillbirths, again, we're looking at the numbers, and we're also looking at the income status within the different regions of the globe. Sub-Saharan Africa, the orange, and Southeast Asia, again, prominently telling us their story. Can we continue this way on a trajectory of a flat curve, like the red line shows us? Or should we aim to go like the high-income countries and have a dramatic decline? That's what we should aim for. But globally, what does it tell us? Maternal mortality ratio, we need to work 9 times harder. Stillbirths, 3 times harder. Neonatal, 4 times harder. And for children under 5, 4 times harder. If we are to see them live, not just survive, but to thrive and participate in development. Again, this is a depiction with emergency care services. Look at this data. Hardly getting to 50%. And in some cases, even budgets are at 20%. Where is the ring fencing of financing for maternal newborn health? National strategies, the lower group, where we're looking at 10 core components that are critical to give successful services. Budgets, a problem. Designing of our facilities, human resource for health, and post-discharge follow-up are all less than 50%, and in some cases as dismal as 22%. Globally, this is what we look at, the countdown 2030. And I've given you a picture that depicts all the arrows are missing the mark. We're not yet at bullseye. Maternal, flat curve. Neonatal, flat curve. Perinatal, flat curve. Extreme left, I'm clearly showing you the inequities, the haves and the have-nots. So what can we do differently? Business unusual and disruption must happen. And this is a conversation I even recently had in Ethiopia. We must put collaborative efforts in country, between regions, and even taking it to the global stage. What is your maternal mortality ratio and rate? When you have a maternal mortality rate of over 1,000, like you see in DRC, you see in Chad, you see in Sudan, it reflects everything is in havoc. There's a weak health system, there's poor quality, there's high total fertility rate, low contraceptive rate, hardly any demand for contraception because of unmet needs. We are somewhere between 300 and 990. What does it tell us? You're beginning to access care, but your health system is wanting and quality is wanting. When the maternal mortality rate gets to 50, to between 50 and 299, we say you're at the crossroad. You're beginning to give a little bit of quality of care. Your health system is getting better, but you find even you still have direct causes of maternal and newborn deaths happening. The chronicity of diseases, such as communicable diseases, are still prevalent. When you have a maternal mortality rate less than 50, now you're moving to middle-income countries. There's lower fertility, better contraceptive uptake, less unmet need for family planning. Quality is definitely mounting up. Health system is much better, but it may also be over-medicalized. When you get to stage 5, all avoidable maternal deaths are happening. Excellence in quality of care. But I have news for you looking at the next curve that still speaks to these 5 stages. Do not assume when you are winning and having no maternal death that you have won the winning. You must take the mothers and newborns together. They're intricately put together. So if your maternal mortality is at 0, look at your perinatal mortality. Aim to get both into stage 5, depicting quality of care. Better survival and thriving of both is what we want to see. And therefore, from global to country level, this is what we say for the management team. You need advocates, you need implementers, like we almost all are in service delivery. You need a metrics group dedicated to doing nothing else but looking at data. So stop renegading your data clerks into a little corner. They turn out to be the most significant to give you evidence synthesis and knowledge translation for you to know whether you're really winning this game. They must form part of your centerpiece. Commodities group, supplies and procurement, particularly of medical products and technologies to assist us in managing the patients. We therefore must integrate, invest, implement, and impact on our patients. Don't remember anything else. Remember this slide. 90% 4 visits, 90% skilled birth. Every woman and every newborn, in 80%, they must be seen within 48 hours of the delivery. 80% must access emergency obstetric and newborn care. And between 65 and 80%, social determinants, which will empower women through education, multi-sector address, and the gender lens must be provided. 90, 90, 80, 80, 80. Remember that. This is our current profile. We're flat. What are we going to do? When we look at even social determinants, we've not even reached the 65% in any of our counties. Central, you're doing much better. But I keep on saying, when you do reach that target, aim even higher. Because the better the outcome, the better the quality of your human capital for you in your nation. We have comparative dashboards. This is a UNICEF drawn up dashboard, which really should be what we're presenting even in our collaborative benchmarking and discussion around Ewene. Look at maternal mortality. The data doesn't even seem to have a well-defined target. Today I talk 355, 352, 530, when you look at the countdown profiling, which is what? What does it tell us about our data sets? And as if that's not enough, all other parameters, acceleration is needed. So we have a lot of work to do and a lot of concerted efforts we must put together. It's not difficult. Give a correct normative environment, give a strong, robust, resilient health system, have human resource, well-trained and competent and motivated, cascading care from community to tertiary facilities and back down to communities. Engage your communities. Provide systems for transport. Provide health insurance that covers the woman from financial hardship. Follow up, follow up, follow up. Be it the mother, be it the newborn. It is a continuum. Today I'm a mother. I give birth to a baby. Tomorrow the baby becomes the child. The child becomes the adolescent. The adolescent begins motherhood. What is the quality of your citizenry as you cascade them through the continuum of care? What is your health system like? What is your delivery platform like? There is a minimum standard, which I have depicted here. What is considered normal when giving antenatal services? What should you have as the minimal core set? And when there is an emergency, what is expected of you? Intrapartum, similarly. Emergency care, similarly, for the newborn and for the mother. I'll ask a simple question. How many of you conduct regular emergency obstetric drills within your facility? Don't need to answer. But if you've ridden in a plane, every time they'll even tell you, even if you're a frequent flyer, pay attention. Why can't we do this for our women and newborns? And even for the children under 5? What can protect and prevent? And how do you treat when a problem arises? There is minimum standards always to be met. Don't forget the stillbirth. The baby that was born that never cried, or the baby that was born was entered into the labor unit alive, but never made it out of that labor unit. What is our data like? Are we really capturing stillbirths or just monitoring neonatal deaths? What are the factors? And you do know macerated stillbirths are an indicator of prenatal care. Fresh stillbirths are an indicator of the events in childbirth. They all tell a story and they matter. Here I've just given a depiction of what are the contexts in which we may end up with a sick, small, vulnerable newborn. And it's clear the value of getting to have an ultrasound and weight estimation early in gestation so that you're able to track through how is the baby's growth and ultimately what does the baby come out as. Are we regularly weighing? Do we have a yardstick to measure? And what are you doing with your preterm babies, where even from the global data, it is clear it is a mounting concern. The small sick newborn, it doesn't change. Your political commitment, your leadership, your financing, your health system, your data, family and community involvement, and post-discharge follow-up. Interventions are simple. Thermal care, kangaroo care, delayed cord clamping. If the baby is coming out prematurely, provision of antenatal corticosteroids and magnesium sulfate. Are we doing this? And therefore adhering to the PREP 5 strategy? Food for thought. Policy, environment, and health financing. I know a lot of obstetricians and gynecologists will say, that's not my purview. But if you care enough to lead, it should bother you. What is the policy of your institution? What is your policy at subnational or county level? What is your policy environment? And therefore your financing and your strategic planning and your acceleration planning. We need a return on investment. But are we tracking this? And are we really looking at data to inform us? Maternal social determinants, I need not labor. Those of you who've come through the university, like most of you have gotten your OBS guide, you don't need to be an MFM to realize social determinants of health are critical. And I will even add one that really disturbs me a lot: malnutrition. and the effect of fetal programming. So the baby from utero is predisposed to non-communicable diseases, diabetes, metabolic syndrome, cardiovascular disease. We need to have a wake up. So when we see that anemic patient, we no longer take it as business as usual. We've got to make a difference. Aggravated that with climate change. Aggravate that with environmental pollutants, the air, the water, the soil. It is sick. But what are we doing and what are we saying? Then we have the community health army. And here I'm giving a comparative with Ethiopia. Yes, we have community health promoters, over 100,000 rapid result initiative in Kenya. But what's the quality of training? What is the quality of updates? What is the context and priorities for the given environment they work in? They must be cognizant of. And referral into the health system and from the health system back to the community. Are we utilizing this personnel appropriately and strengthening and upskilling them? Where are we? So on the global stage, we have six acceleration progresses that must be in place. Strong leadership, adequate resources, strong partnership. Invest in all stages of the life course, quality and equality. Facilitate subnational planning, budgeting, and implementation monitoring. Standardize and prioritize improved data flow. Galvanize collaborative and multi-sector partnership. All this becomes useless if you're not having progress reports. And this requires coordination, prioritization, and implementation. We must become the stewards that embrace technology. It's no longer just our technical expertise or evidence synthesis. We must also strengthen cross-learning, benchmarking, and knowledge translation. Tracking. How do we track to get to bullseye? Accountability tools. Relook at our civil registries, our community verbal and social autopsies, your MPDSR. When you conduct demographic health surveys, take them critically. Healthy mother and newborn networks, we must have these in place. And performance of your routine data. This is what we must look at. Quality, quality, quality. At the bottom of this slide, look at the picture at the bottom. I will not state which hospital you were or I was in when I took this picture of the data, patient files. Can you make sense out of that garbage? Garbage in, garbage out. Organize your filing system. Better still, put it on an online mechanism. Best still, even begin to integrate with other data sets from other sectors such as finance, education, agriculture. You begin to get the globus picture of what is needed for every woman, every newborn. Therefore, quality of care means this. It must be effective, safe, people-centered, efficient, integrated, timely, and equitable. We must challenge ourselves to this. But what else can contribute to quality of care that we must think about? Institutionalizing a work culture. Continuum of care is the mother-baby dyad. Meaningfully engage with communities, address health inequities and the rights of vulnerable and marginalized persons. Systemic thinking, advocacy, and accountability. This was a study done over 10 years called Safer Births Bundle of Care in Tanzania. And what are they saying? It's not enough to just train. There must be clinical innovations in the process, continuous quality improvement, what we used to call the Kaizen, and sustained efforts to make it better with every new day. We have measured for the longest core indicators, as I mentioned throughout this presentation. But I want you to begin to start seeing the kind of quality indicators which looks and speaks to qualitative studies, maternal well-being, the neonatal mental status, management of anemia, fetal heart rate on admission, monitoring, and responsiveness to the same. Identification and management of PPH. We're now talking about engendering PPH management. So we need to begin to see it's not just about what we're used to monitoring. Individualized data tells stories. Lived experience of mothers are equally important in addressing satisfaction and the kind of quality she's demanding out of us. It's not just about respectful care. Even when you have a bad outcome, what is your bereavement care plan with her? And do you have functional referral systems? These are things that we need to begin to look at. Ladies and gentlemen, I hope I have provoked you to think a little bit deeper about providing quality, sound maternal newborn health care for their survival, for them to thrive, and to note they are the capital of today and tomorrow's generation. And I'd wish to invite you to FIGO World Congress. It's coming. 5th to 9th October 2025. Please engage with me. Let's have a date. Let us celebrate together our gains, learn lessons, and at the same time, challenge ourselves all the more. We are on the African continent. We should make a difference. Thank you very much.